Welcome to Rheumatology Virtual Grand Rounds. I'm Dr. Len Calabrese from the R.J. Fasenmyer Center for Clinical Immunology. And today it's a great pleasure for me to introduce my colleague and good friend, Gregg Silverman, who is a professor of medicine and pathology in the Division of Rheumatology at NYU in New York City. Dr. Silverman has spent his entire career studying B cells, humoral biology, and is a renowned expert on lupus and emerging therapies. And today he's going to talk to us about managing chronic non-renal SLE.
Hello, I'm Gregg Silverman, professor of medicine and pathology in the Division of Rheumatology at NYU School of Medicine, and I welcome you to this program that's part of the Rheumatology Virtual Grand Rounds. And our presentation today is entitled Managing Chronic Non-Renal Lupus. Our learning objectives include: we will discuss clinical presentations that can aid recognition of systemic lupus erythematosus. We'll also describe the general principles of disease monitoring and define the therapeutic options that are available for patients with skin, joint, and constitutional symptoms. And lastly, we're going to describe the risks associated with commonly employed therapies in the management of chronic lupus disease. We'll start with a case study. So a patient presents to our rheumatology clinic. She is a 23-year-old Hispanic female who complains of fatigue, new rash, and joint pains of about 1 or 2 months duration. Otherwise, she has no significant past medical history. She's on no medication, and she doesn't have anything to suggest that she would have risk factors for HIV or hepatitis exposure. Her family history is intriguing, however, because her mother has rheumatoid arthritis, and she also has an aunt that has lupus. Her physical examination shows that she is afebrile, she has a borderline blood pressure that's 150/90 and a pulse of 84, and a respiratory rate of 18. She's probably a little anxious. The patient appears pale, and she has a erythematous facial rash that's non-raised. She also has tender and swollen MCP joints and wrists that are diffusely tender and swollen, but without any nodules. There's no subluxation or joint changes otherwise. And bilaterally, she has knee effusions, but no other joint involvement. So here we see an example of what her rash looks like. So this is a classic butterfly rash. It's all over the malar eminence, and we can see that it has very characteristic findings, that it spares the nasolabial folds. By history, she tells us that it may increase if she has a fever, and she's felt a little feverish, although that was only on close questioning. Otherwise, she doesn't have anything on her forehead. She has no rash elsewhere. So this kind of rash, we know we associate with lupus. It can be present at some time, and up to about 46 to 65%. About half of patients with lupus will suggest that they've had a rash at some time. But it varies greatly between individuals and actually what it looks like. And the point that I wanted to make is that this rash is actually not diagnostic for lupus. And in fact, lupus patients can suffer from virtually any kind of rash. So if the rash looks differently, it doesn't mean that it's not lupus. In fact, you can even have macular papular rashes. You can even have bullous rashes. So the rash can look and be of many different features. And so you shouldn't see a rash that is not a malar rash and suggest that this is not what the patient is suffering from. So we're going to have a question now. What features of the clinical presentation of our patient may suggest SLE or related illness? A, gender; B, age of onset; C, ethnicity; D, family history; or E, the clinical specific features at her presentation; or F, all the above. So think about it for a second. And the reality is this is a very characteristic patient. All of those features are very, very characteristic. And if I saw her in clinic, it would raise my suspicions greatly. So in general, lupus is a female predominant disease. In large groups, it's about 9 women for every 1 man that will develop this disease. Onset in women actually can occur at any age of life, but is most common in the 3rd to 4th decade. Rash is a very common presenting symptom, as are musculoskeletal symptoms, and these can actually be the the predominant complaint when patient presents. This patient's family history is very worrisome. And why is that? It's because of family history. If it's positive, suggests there may be some genetic factors that are contributing to susceptibility, and now over 30 different gene variations have been associated with lupus susceptibility. Some of them are actually overlapping with other autoimmune diseases, including RA, which is what's intriguing about her relative that has rheumatoid arthritis as well. But while this patient seems to have so many different red flags going up, in some individuals, it can be an elusive diagnosis, and you should appreciate that lupus can present at any age in life, both in infants all the way to people in their 6th, 7th, and 8th decade, although clinical features that are predominant differ. So what laboratory tests should we order? There may be more than one answer that's correct. A CBC with differential, a chemistry panel, C, urine analysis, D, an antinuclear antibody by immunofluorescence with an anti-Rho and LA and perhaps complement levels C3 and C4. E, a multi-panel autoantigen-specific ANA, which is increasingly offered. And there may be more than one answer that's correct, so perhaps it's F, all answers except E, or G, all answers except C. So think about this for a bit. Not to say this is more personal preference, although I think most people would agree that, in fact, all of those tests are warranted at this time of evaluation because the patient's presentation is highly suggestive of lupus. Personally, I don't actually think that initial evaluation should include these autoantigen-specific multi-panels. And in fact, in ANA, when done properly, if a reference laboratory can perform this, there's so much more information that has to do with the pattern in the antinuclear antibodies when they're incubated, usually with a Hep2 cell line, and that actually can direct you towards a better diagnosis. And in fact, if one instead used a multi-panel autoantigen ANA, you may in fact miss many positive results otherwise that would be detected by immunofluorescence. So if possible, this sort of sequential use of a screening ANA followed by, if it is warranted by a positive ANA, should be considered. We should also think about possible dermatology consult for our patient with rash. If we're thinking that this patient is really clinically unstable and therefore might warrant clinical intervention, therapeutic intervention, we might think about it at this time or shortly thereafter, getting hepatitis serologies, and also screening for possible TB exposure in the past by a classical skin test. Or increasingly, people are using interferon gamma release assays, the IGRA indicated here. This is a more expensive test, but in some cases it's warranted, particularly if people may have a history of past BCG vaccine exposure. There are no false positives based on past this vaccine exposure, and that can provide some advantages. And also considering alternate diagnoses and other considerations that may come up with regard to the chronic condition or further management, which we'll discuss. So now we're going to go on to another question. Antinuclear antibody production is common in lupus. What is known about the association of these autoantibodies with lupus? A positive ANA test is diagnostic for lupus. B, if your ANA test is negative, the patient definitely does not have lupus. C, only nuclear antigens are recognized by lupus-associated autoantibodies. Or D, only rheumatologists should order ANA tests. Or E, based on animal models and in vitro studies, ANA autoantibodies may play direct roles in the pathogenesis in lupus. So think about this. Actually, all of this is relatively controversial, and this is my personal preference. I would actually say that the other choices are not true. And in fact, there is evidence, experimental evidence, that some antinuclear antibodies can actually contribute directly to pathogenesis. If we review the other choices again, you should appreciate that ANA is not diagnostic. We need more specific criteria than that. And in fact, people can have negative ANAs and still have lupus. Usually there are antibodies of other types, which we'll discuss, and that in fact these are not necessarily only nuclear antigens, although they're predominant. While a ANA can be a useful screening test, it should also always be used in the context of clinical presentation. In fact, there's a billing code where it's a positive ANA, but the patient does not have lupus, so this comes up quite often. So ANAs are present in more than 5% of the general population, while lupus and related conditions are much more rare. It does indicate that there's some dysregulation in the immune system, but it doesn't necessarily mean that you actually have an overt disease. While it is true that almost 100% of all people that truly have a diagnosis of lupus have some kind of autoantibody, and most of those, the great majority of those, are going to be positive for an ANA, and then we may be able to find positive tests for other nuclear antigens. Some individuals have negative ANAs. They actually have antibodies to ribonucleoproteins like Rho and La, and other individuals, even if they're completely negative for both types of tests, might have antibodies to phospholipid antigens. But again, most lupus patients are ANA positive. So not everyone with an ANA develops lupus. It's a pretty good screening test as a first step. We should also appreciate that there are specific types of autoantibodies with known molecular specificities, and important of which is to consider that 40 to 70% of lupus patients at some time will have a positive test for antibodies to double-stranded DNA. These are very specific for lupus. There are very few individuals that will have these positive antibody tests and not have lupus. I have to say I'm always very concerned if this test is positive, but not all the clinical features we're going to discuss are present to allow a diagnosis. And people that have anti-DNA antibodies are at greater risk of developing renal disease. And in some studies, in some individuals, actually ANA titers, anti-double-stranded DNA titers, to correct myself, can actually be raised during flares, and complement can drop C3 and C4, but in large groups, this is not always the case. So it may provide some value in looking at an individual with a known history with correlation with lab test changes. Not good in general screening, though. In initial evaluations, you wouldn't actually test for these unless you had a very high index of suspicion. So let me just remind everyone that to make a diagnosis of lupus, we generally follow the ACR criteria. These have been around for a long time and have been evaluated to see their utility. And there are 11 different criteria, and to actually make a diagnosis of lupus, it's suggested that 4 criteria be positive, and they don't have to be simultaneously positive. They can be positive at any time. And I'm going to point out that this may be a useful resource, and you can download this from the website for your future consideration. So antinuclear antibodies are quite intriguing. They are not actually only associated with lupus, and this is a very old slide, but I think very illustrative. There are a number of different molecular fine specificities that are recognized by autoantibodies in individuals that will have positive ANA tests by the screening test, and these include, as we see at the bottom, single-stranded DNA, which is very, very common. It's not very specific. Antibodies to histone, which can be present in different conditions, which, as I'll discuss. Antibodies to ribonucleoprotein. A related protein is SM. It's double-stranded DNA and SSA and SSB, Rho and La. Then there's SCL70 and centromere antibodies. The point is this shows relative occurrence of these specificities in people that have different diagnoses. So more common in the past, when other medications were more commonly used, like procainamide, people that had really a drug-induced condition, and this is a very diverse set, but people that had procainamide-induced systemic illness, and prominent rash and joint disease, often only had antibodies to single-stranded DNA and histones. Sjogren's can be very overlapping with lupus, and we can see that a number of different specificities, and very prominent is antibodies to SSA and SSB, while antibodies to, for instance, double-stranded DNA are distinctly uncommon in this condition, and they're also uncommon in mixed connective tissue disease. But you can see in lupus, the same individual, in fact, can have multiple autoantibodies, but the greatest specificity is generally associated with antibodies to double-stranded DNA and SM antigens, so they can help confirm a specific diagnosis. And in some cases, these particular patterns may have some prognostic value. So moving on, now we're going to talk about features of lupus and stages of disease. Lupus can have diverse disease manifestations, but what do we know about clinical features and organ involvement at presentation compared to later stages of the disease? Is it true that A, organ involvement does not change over time in an individual? Or B, in cohort studies, joint and skin involvement are often present at initial evaluation diagnosis. C, renal involvement in a patient almost always is detectable at first presentation. D, certain specificities of autoantibodies are associated with greater risk increase with regard to specific disease features, and I think I mentioned this earlier. E, lupus is rarely associated with other forms of autoimmune disease. So more than one of these answers may be correct. So for F, both B and D are correct, or G, A, and D are correct. So there's a lot to consider here. I think that the correct answer is that both B and D are correct. And in fact, it does turn out that there are multiple papers that have shown that organ involvement can actually change over time, so you have to be vigilant. Things may evolve. While it's true that joint and skin involvement are often present at initial evaluation, renal involvement can arise at any time point, and not necessarily will be present at the first diagnosis. And there are cases, in fact, where specific autoantibodies, in particular anti-double-stranded DNA, is increased risk of developing renal disease, and some studies say CNS disease as well. And in fact, lupus often is associated with other types of autoimmune diseases, and thyroid disease comes to mind as being very prevalent, but there are many overlap syndromes. So the best study, from my perspective, on actually the evolution of lupus was a paper that appeared in 2007, Heinlein et al., and I refer you to this reference. It looked at 130 patients that were diagnosed. Interestingly enough, they're all women in the military, and they were able to actually look through their clinical records and look at how they presented and also how the disease evolved over time. So it provided a unique opportunity to look at the evolution of the disease. Arthritis was most commonly observed even before diagnosis. So patient complains of arthritis before they made the criteria or before they had a evaluation where it was all put together. And again, anti-double-stranded DNA can be associated with renal disease. But in this cohort, these autoantibodies were present before there was an abnormal urine analysis or evidence of renal impairment. Here's a very important slide from this paper. And what it shows you here depicted in red, we can see that at presentation, the tallest bar clinical manifestation at presentation, most prevalent presenting clinical feature is arthritis. And you can see that in the black bar represents whether or not this organ system involvement was present at any time during the history of the disease, during the period of follow-up, which was up to about 9 years, and before the diagnosis, and 6 years after the diagnosis. And you can see that arthritis is also more prevalent. And it's greater than 90% of the patients would have arthritis at some time, and you can see the relative prevalence of other features. So thinking about lupus as such a diverse condition, where each individual I truly think is really unique and may have their own path, in fact, for the development of an autoimmune condition and different clinical involvement, it can actually be very challenging how to manage someone over time. And I refer everyone to this really important paper, Mosca et al. It's actually in the Annals of the Rheumatic Diseases, and it's a recommendation from the European Union League Against Rheumatism, the EULAR organization. And it really is relatively comprehensive, and it suggests that each patient be rigorously evaluated and also keeping in mind whether other comorbid states may develop. Lupus patients are at very increased risk for the development of cardiovascular events, heart attacks, and strokes. We should be very aware of traditional risk factors like diabetes, cigarette smoking, family history, and so on and so forth, as well as lipid abnormalities. And there's a number of different tests that are suggested to look for these comorbid states, as well as consider the patient's lupus increased risk in part from medications for osteoporosis, and think about those risks. Patients are immunosuppressed based on the disease, but also based on therapy, and think about other complicating conditions from hepatitis to HIV, as well as reactivation of viruses, including herpes zoster. And it's recommended here that even if patients have no disease activity evaluated, no evidence of damage, and no other comorbidities, they still should be evaluated on every 6-month basis. Patients that are more unstable should be seen more frequently. And laboratory assessment, there are some things that should be done routinely, and others that need really only be done infrequently. You don't need to repeat the ANA over and over again, and most autoantibodies are not going to change. There may be a reason to get complement levels during disease activity, and also we should always think about antiphospholipid antibodies and risk of clotting events, particularly during pregnancy or when people are stressed through surgery or transplantation, or estrogen-containing treatments are controversial, but still should be considered whether these could be triggers. And again, I refer you to this reference for greater detail. Time limitations forbid us going into greater detail. If you suspect at all that the patient has renal disease, and everyone should be considered because it's so prevalent of a condition, screening tests with urine analysis and looking at BUN and creatinine, and if there is in the urine evidence of proteinuria, getting a 24-hour collection, looking at protein creatinine ratios compared to blood is very important, as well as potentially in some individuals a referral for renal evaluation if indicated. Other complications like mucocutaneous involvement, neuropsychiatric manifestations, and eye assessments, and particularly you should consider a routine ophthalmologic evaluation for patients on glucocorticoids and antimalarials, which we'll discuss more. There are certain risks associated, and a lot of the risk can actually be reduced with vigilance and assessments relating to potential complications of therapy. And virtually every medication that we use has associated toxicities and risks, and also point out that patients on cyclophosphamide for renal disease or other indications are really at greatly increased risk of premature ovarian failure. And all the toxicities and all these risks should be considered with every therapeutic decision. So what therapies are available for the treatment of lupus? So I wanted to make a point up front that, in fact, standard of care for lupus includes agents that are FDA approved, but actually includes many agents that have not been FDA approved, and they still nonetheless represent standard of care. Lupus is a difficult disease in part because of its heterogeneity to study, and I'll point out that, in fact, historically, there have only been 3 medication types that were long-term approved by the FDA for the treatment of lupus: corticosteroids in the different forms here listed. Prednisone is perhaps the most commonly used on a daily basis. Hydroxychloroquine was approved. There is another antimalarial that can be used as well, an earlier form, chloroquine, which may provide some advantages. Mechanisms of action are both relating to different approaches to immunosuppression, and aspirin. And really, there were these three medications were the only that were approved by the FDA for the longest time. They were approved between the late 40s and 50s, and these are really grandfathered in. So Belimumab is an antibody therapy, a biologic agent, which is now FDA approved for the treatment of lupus. And its mechanism of action is very complex. It decreases B-cell activation. It targets a B-cell survival factor, and there are studies that suggest that it may decrease autoreactivity of the B-cell compartment. But most importantly, it really is the only medication that is FDA approved based on randomized controlled trials, and it is currently only approved for the treatment of non-renal lupus, but studies continue. And it's postulated to restore the balance in the immune system in part by acting on autoantibody-producing B cells. There may be other mechanisms by which it acts as well, but it's very targeted, specific therapy. Treatment with Belimumab has been associated with improvement in overall disease activity and reductions of subsequent flares, and this has been looked at a number of different organ system involvement. Also, belimumab has been shown to decrease the daily requirement for corticosteroids. So there's a lot of toxicity with corticosteroids, and belimumab may decrease the need for substantial doses. And again, this was actually the first phase 3 randomized controlled trial of a new biologic that succeeded in meeting its primary endpoint. So not only were these findings very important, but in fact may also help to define a path for clinical trials in the future for other agents and for refining therapies. There are a number of other therapeutic opportunities or choices that the treating physician has to consider. They are considered standard of care in many cases, but with different levels, I would say, of validation. Nonsteroidals are commonly used for the treatment of arthritis symptoms. Again, they have their own toxicities. Antimalarial agents, aside from hydroxychloroquine, which I mentioned, cytotoxic agents and other immunosuppressives from cyclophosphamide, azathioprine, methotrexate, and cyclosporin, to just name a few. There are others that have been used as well with success. For mycophenolate mofetil, a drug that was introduced for organ transplant patients to control the development of rejection, this agent reduces immune activation, and randomized controlled trials have shown it to be as effective as parenteral cyclophosphamide in treatment of renal lupus disease. It was not shown to be superior, and there was no submission to the FDA. There's also been some studies that are very convincing that have shown there can be benefits for non-renal lupus as well. And these are non-superiority tests studies. In addition, in the proper patients, anticoagulants may be very useful, and particularly in the setting of thromboembolic disease or fetal wasting associated with antiphospholipid syndrome. And then there are many other therapies that have been used, and this list is not meant to be exhaustive, but they can include, for the right patient, plasmapheresis, usually used in addition to a immunosuppressive. Thalidomide has been used, many risks associated with it, especially in young women. And then there are actually agents like DHEA, which is a kind of an attenuated steroid. And at the present time, there are a number of other biologics that are being considered and have been shown in some case studies and in some open trials to potentially have some benefits, although each is very controversial. Rituximab anti-CD20 therapy, which is FDA approved for the treatment of RA patients with inadequate response to TNF blockers, and the list is just partial, but many are currently in development. So for our question 5, what medication should I prescribe for a patient with non-renal lupus? So the answer could be A, many or most clinical manifestations of lupus are likely to respond to glucocorticoids or other immunosuppressive agents. B, standard of care for non-renal lupus in most cases is primarily based on open trials, observational studies, and cumulative clinical experience, and not randomized controlled trials. C, most clinical studies have focused on organ-specific responses, and patients may have many organs that are involved. Or D, therapeutic choices should be individualized to the patient and must always consider associated side effects and toxicities. Or E, all of the above, or F, none of the above. So I think the correct answer is all of the above. In fact, in my training and in my clinical experience, I've found that most lupus patients and most clinical manifestations will respond to either glucocorticoids or other immunosuppressive agents. The question is, what is the toxicity, what is the dose, and how well is this tolerated over time? And if you start such agents, what is your ongoing plan? And glucocorticoids at high doses are very likely to be toxic the longer that you carry a patient on high doses. And again, standard of care for non-renal lupus in most cases is not based on randomized clinical trials. In fact, there are only a couple of cases, and I pointed out belimumab, showing superiority in randomized clinical trials and leading to FDA approval, and MMF actually showing comparable responses to other agents and a level of efficacy. And most other agents really have much more limited experience. Right now, we're seeking to develop these composite indexes that look at multiple organ system involvements. They were shown to be useful in a couple of cases. It's still a process in evolution. We should remember that the American College of Rheumatology scale for rheumatoid arthritis trials was something that was developed over time and actually provided really a wonderful platform for evaluation of medications, but it took a while to develop, and we hope that lupus, which is really a much more clinically diverse condition, similar kinds of approaches can be developed. But in general, I would say that therapeutic choices have to be individualized to the patient, and you have to think about disease activity as well as each therapeutic choice has its own potential side effects and toxicities. So now I've provided a list of what I would say would be amongst the most common toxicities of agents for lupus that are commonly used. I have to say virtually every agent is also associated with the potential for nausea, vomiting, and diarrhea. I've provided a brief list for amongst the most commonly used agents, and this is not meant to be comprehensive, but one should consider what are the most common side effects of each approach. Glucocorticoids are by far the most commonly used therapeutic approach, and they put the patient at risk for infections and serious infections, life-threatening infections. Glucose intolerance is not uncommon, hypertension, GI bleeds, other conditions can occur as well, and particularly the risks increase when you get above about 20 milligrams a day. Again, this is really my personal judgment on this, but I think most people would agree. Nonsteroidals can be very helpful, but put the patients at increased risk for GI bleeding, sometimes life-threatening. Hypertension, there's a cardiovascular risk for myocardial infarction, other risks as well. Antimalarials are generally very safe and very well tolerated. There is the greatest risk of retinal injury, and there are other associated potential risks as well that are listed. But I have to say with ophthalmologic evaluations, particularly in patients over 40 years of age, these should be conducted on a regular basis. Some papers suggest yearly, some suggest every other year may be sufficient, but with proper vigilance, really the chances of developing a irreversible injury with implications for vision are really very modest. It can be managed. Azathioprine, of course, is very immunosuppressive, can put the patient at risk of serious infection as well as impairments of red blood cell production, platelet production. There's also associated cancer risk. Cyclophosphamide, our quote-unquote big gun that we keep in reserve for very serious life-threatening complications of the disease, is very potentially immunosuppressive, great risk of serious infections, bone marrow suppression, and I reiterate, ovarian failure as well as increased cancer risk. It should be used judiciously, and there are, in fact, some fertility protection approaches which may be considered in a properly selected patient. Methotrexate can be very helpful, particularly for joint disease, but in fact does also cause immunosuppression, increased risk of infection, bone marrow suppression, and of course, liver injury leading to fibrosis is a great risk, and this can be a very problematic agent in a setting of a patient who may be in the future seeking to have a family, and I think that I should reiterate that contraception and the risks of fetal injury should be reiterated at every juncture with such patients. Mycophenolate mofetil provides wonderful opportunities for clinical responses in many individuals, but diarrhea is not uncommon as we try to push the dose to higher efficacy. Serious infections can occur, liver injury as well, pancreatitis. And Belimumab, this targeted therapy against a B-cell survival factor, although there are potential risks associated with it, and I would point out that the clinical trials showed a couple of cases of suicide in the patients getting the active agent, not really well explained, although there are mood effects associated with the disease. But in general, the most common adverse associated effect were infusion reactions, which were generally well tolerated. So this is an agent that provides new opportunities and is really generally very safe, at least in experience to date. So that list was far from exhaustive, and I actually didn't suggest how we manage some of these risks, but I refer you to this reference in the Seminars of Arthritis and Rheumatism, which provides a much more comprehensive explanation of how we manage risks, what we should be monitoring over time. And I think that this is a useful resource for everyone managing lupus patients. And specific testing and intervals is suggested as well. So, having discussed the management of patients with non-renal lupus, I think some of my comments is that there remain great unmet medical needs in patients with lupus. The chronic nature of this relapsing, remitting disease leads to organ damage, accrual over time. Mortality and morbidity are increased compared to the general population. Therapeutic advances over the last few decades have led to significant improvements. In the 50s, there was about a 50% 5-year survival. But in fact, this has improved now in that more than 90% of patients will be alive after 5 years, and we're optimistic that this prognosis will improve over time. Key is early diagnosis, but this can remain a challenge, and diagnostic delays can lead to a delay in starting definitive therapy. Therefore, we need to develop better methods for making a diagnosis and for better monitoring treatment responses as well as toxicities. And over time, we hope to develop more sensitive biomarkers to aid in management. So for concluding comments, lupus is an autoimmune disease of diverse clinical presentations and organ involvement. Premature cardiovascular disease remains a leading cause of morbidity and mortality. There was enough time to discuss this, but there have been some studies that suggest that in young women in particular, they can actually have a 50-fold increase of risk of myocardial infarction. This is a population, and otherwise, this is an exceedingly rare clinical issue. So it should be kept in mind, patients presenting with atypical symptoms and features of the disease. And in fact, we have to develop better methodologies for screening and for evaluation. Fatigue is one of the most disabling symptoms in many lupus patients and will contribute to a poor quality of life in many of these patients. Current treatment regimens rely heavily on corticosteroids, even though corticosteroids are well known to cause organ damage. So there's efficacy, but there's also risk associated. So evaluations, therapy, and regular follow-up must be tailored to the needs of the particular patient. We need to integrate treatment of lupus flares, comorbidities, and potential drug toxicities, amongst other factors that we consider in the care of our lupus patients. So I refer you to this paper by Michelle Petrie, a leader in the field, and I thank you very much for your attention. And I hope you'll not only benefit from this program and download some of the tables to aid you in continuing management, but also to make use of other programs being presented in this series. Thank you.
Thanks, Greg. That was really exceptional. You know, the take-home points that I have kind of derived from your talk is that lupus is still a complicated matrix of decision-making, and it is a big disease. People can have it virtually asymptomatic or life-threatening, can be in multiple organs or in a single organ. And while we have a lot of clinical trials that have focused on renal disease, non-renal disease is still a bigger problem and a more common problem. I think you've outlined nicely the drugs on our palette. I think we all need to be heavily engaged with anti-malarials, and I think we are all learning where biologics fit in, particularly Belimumab. I think it's a very interesting drug, particularly for non-renal lupus, because that was the study population, as you pointed out. But it is not a rapidly acting drug for our sickest patients, and only experience will tell us where it will ultimately fit in our armamentarium. I think there's some interesting things in the pipeline, but they're not ready for prime time. And again, thank you for an outstanding presentation. I'd like everyone to come back and look at some of our other outstanding cases in the Virtual Grand Rounds library and come back to our website often. Thanks.